Welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy. And this video is a continuation of the Express Revision course for oral surgery. And before we get started, make sure you subscribe to the channel and hit on the bell icon so that you don't miss any of our exciting videos. And also you can check out our playlist for more interesting videos. And there is a link provided in the description box below for the notes of this particular video lecture. And if you are interested in reading more notes, you can check out our website www.xtooth.com. So let's get started with today's topic. So we have covered that when a patient comes to the emergency department after some trauma or fracture, the first thing we need to do is maintain the airway, breathing and circulation. That is the utmost important thing, first thing which we do. And then we have studied that either we have to go for a closed reduction or we have to go for the open reduction, that we see what kind of fracture the person is having. Say suppose if a person after trauma is having undisplaced fracture, say suppose this is the mandible, and if a person is having fracture line like this and there is no displacement of the fracture segments, that means the mandible remains in the same position. But what if the person is having, say, a fracture like this and the fragments are displaced? Now say the fragments are displaced like this. So in this situation, we have to go for the open reduction. We are doing the surgery and then we are putting the plates or screws. So today's video, we will be covering the internal fixation, basically the fixation wherein we are going to put plates or screws, doing the surgery, exposing the bone and then putting the plates or the screws. So that is the fixation. So we have got some principles of fixations that we will be covering in today's part. So first of all, we will be covering the internal fixation. See guys, we have studied in the previous part that intermaxillary fixation, that means bringing the maxillary and the mandibular teeth in a close contact and then remain it like that. This is what we do when we are doing the closed reduction. That means when we are not going for a surgery, we are fixing the maxilla and the mandible together. So that is the closed reduction, when the fracture segments are in its position, when they are favorable fracture or when there is non-displaced fracture, we go for the closed reduction. But if there is, say, displaced fracture, unfavorable fracture, all these situations, we have to surgically expose the area and then put the plates or the screws into it, and this is what we call the internal fixation, right? So either we can do it with the help of wires or we can do it with plates or we can do it with the screws. So today lecture we will be starting with the plates. Now we want that the segment, fracture segment, if it is not moving, then we go for the absolute stability, that means the rigid fixation. Then if there is some movement happening between the fracture segments after you have plated it, but still there is some movement, which is some micro movement or some movement is there, then we call the non-rigid or the semi-rigid fixation. So guys, first of all, we have got the first principle is rigid versus semi-rigid or non-rigid. Semi-rigid or non-rigid fixation. When do we have to go for the non-rigid fixation? When do we have to go for the rigid fixation? That we decide according to the fracture. So before understanding it, let's understand the term stability. If there is no movement of the fracture segments after you have done the fixation, say suppose this was the fracture and this was the fracture, this is before you have done the reduction. So surgically you have done the reduction of this fracture, you have taken both these fragments together and then you have put a plate over here. Say suppose with this hole in between, here we have two screws in this plate. So once you have fixed this fracture, that means once you have done the plate fixation, after that if there is some movement of these fracture fragments If you see these two fragments, they are showing some movement during say chewing or say any functional movement. If there is some movement, we call it. So if there is very little to no movement, we call it the absolute stability, which is like close to no movement or can be very little movement. If there is quite some movement after you have put the plates, that is called the relative stability. It depends on what kind of fracture the person is having. So this is about the stability. Then guys, when do we have to go for, see, if you are doing the absolute stability, that is seen in the rigid fixation. So rigid fixation is a kind of fixation wherein there is no mobility. So we can say that absolute stability we see in case of rigid. But in case of non-rigid, there is some movement during the functional, during the person is having any functional chewing or say anything. So this is functionally stable, but still there is some micro movement happening at the fracture segments. So that is we see in case of non-rigid or semi-rigid fixation or semi-rigid. Right. Now try to understand something. If this is a fracture, if this is a fracture segment, say here is the anterior part of the mandible. So say if suppose this is the fracture line. Now what you have done is you have, when you have placed a plate over here. Now placing a plate again depend on the Champy's lines. So we have to look for the Champy's lines of osteosynthesis. So basically these are the lines along which we put the plates or we put the screws. So I have to draw a mandible first in order to make you understand what are the Champy's line, guys. Say suppose this is the mandible. This is the mandible. Now these Champy's line are basically a line along which the bone formation takes place. So there are two lines in the mandible which we see. One line is from one side angle to another side angle, which is seen in the upper border, and these two, the upper border line or the first Champy line, it is going to divide it into two parts. Now close to the angle, one is which is going towards the external oblique ridge, another one which is going laterally. So same goes with the other side, one is which is going towards the external oblique ridge, another one is going laterally. So this is the first Champy's line. We have one more Champy line in the mandible which is present in the anterior region towards the inferior border of the mandible. So towards the base of the mandible there is one more line, but it is extending only in the anterior region. So whenever you are placing the plates, it is very easy to put plates at the point wherein there is bone formation. This is the significance, guys, of Champy's line, that we know that this is the line wherein the bone formation takes place. And if we are putting the plate, say in case, now here we have got a fracture, suppose say this is one fracture present at the angle. Now if you are putting a plate over this Champy's line, then the bone formation will easily takes place and there is going to be a neat you can say bone formation. So at one plate you have to put at the superior border of the mandible if the fracture is at the angle of the mandible. But if you say that if the fracture is present in the symphysis or the parasymphysis area, basically at the anterior region, we have to put two plates. Either you can put two or more than two plates, or you can go for one plate, one screw, like that. So basically we have to do the rigid fixation because there are two reasons to it. One, if there is fracture in the anterior region, then all the muscles which are attached here, the geniohyoid, genioglossus, they are going to pull this fragment back posteriorly. So we have to give a rigid fixation. So in order for no movement to take place, we have to give more than two or equal to two plates. Either there can be like one plate, one screw, there can be two lag screws, there can be two bone plates. So for rigid fixation, which you are doing in the mandibular anterior region, so in case of say symphysis or parasymphysis fracture, So mandibular anterior fracture, I'm just gonna write. So what we have to do, we have to make it a rigid fixation. So for that we need at least more than or equal to 2 points of fixation. And how can we achieve it? See guys, arch bar is when we are doing intermaxillary fixation, we are fixing the teeth, right? So our main motto is placing one plate up in the superior border of the mandible, placing one plate below in the inferior border of the mandible. And that's how, see, if we are placing two things, either they are two plates or one plate, one screw. So either it is two lag screws, which we will be covering guys in this part of the lecture only, or we at least put minimum more than or equal to two plates, bone plates, or we can do is one plate plus one screw plus one lag screw. That is also going to work. Or we can screw the upper border. Instead of screwing or plating the superior border of the mandible, we can fix the teeth. So we can put arch bar also. Upper and lower we are putting one compression plates. Guys, compression plates and all we'll be covering, don't worry about it right now. So we are putting compression plates with the 4 holes. Or either you can put only one plate which is having 6 holes, compression plate. Or you are either putting a reconstruction plate which is quite bulkier plate. So guys, these are the method you can go for the rigid fixation. So basically you are securing it from the top and the bottom so that there is no movement of these two fracture segments. One is this fracture segment, another one is this fracture segment, and we are securing it from bottom to tip to bottom. So for there is no movement which is taking place. That is why we are taking it as a rigid fixation. But guys, what happens if there is a fracture in the body, or say if there is a fracture in the body or angle, there is only one plate which is enough, right? So that is, we are putting in the superior border of the mandible, wherein we have got the Champy's line. So above the inferior alveolar canal, because we do not want to injure the roots of the teeth. So we are placing a plate in the superior border of the mandible where there is a Champy line, or you can put one plate in the monocortical area involving only the buccal plate, only the buccal bone. So you can also put one plate which is only involving the buccal cortical plate, with or without the arch bar, or compression plate with the 4 holes, or one lag screw and arch bar. Basically you are going for the non-rigid fixation here, non-rigid fixation. Right, now we know that we have to put the plates along the Champy's line, and we have got 2 Champy's line, one in the superior border of the mandible, another one in the inferior border of the mandible, guys. So these are the, we'll just go back, revise again, the 2 Champy's line. One is in the superior border of the mandible, which is dividing into external oblique ridge, and another one is going laterally and lateral surface, and the another Champy's line is present in the inferior border of the mandible, which is present in the symphysis and parasymphysis area, basically through the center of the mandible. See guys, what happens if there is a fracture which is present at the, say, in the anterior region? There are compression, tension, as well as the torsional forces. So there are twisting forces which is taking the mandible back. So all these forces, because of that we have to go for the rigid fixation in the anterior region, and for that we have to put minimum of 2 plates, either plate or screw combination, but we have to screw it up from the top to bottom for the anterior region if fracture is in the mandible in anterior region. If it is an angle, say, or on the body, then we can go for only one fixation plate, only one compression plate, which is mostly like 2.4 millimeters. So guys, next principle, first principle is go for rigid or non-rigid. Second one is, second principle is either it is load bearing, that means the plate which you are placing is bearing all the load, versus the load sharing. Load sharing, as the name suggests, the bone shares the load. The load whichever is coming to the fractured bone, plate is also taking up that load, bone is also taking up that load. That makes it the load sharing. So load bearing means all the masticatory forces are at the segment which is bearing the plate. So say for load bearing, guys, all the load is taken up by the plate. For load sharing, the load is taken up by plate plus bone. So during all the functional movement, entire load of the functional activity is taken up by the plate which is fixed on the mandible. So basically, in case if say there are comminuted fracture, we know that the bone is broken into so fine pieces that we cannot let the bone taking up the load, otherwise there will not be any healing process. So wherein there is very little bone interface, either due to the atrophy or due to the fracture, in such a way that we do not want the fracture fragment to take up the load, we go for the load bearing devices. So most common example for a load bearing device is basically our mandibular reconstruction bone plate. So this is the mandibular reconstruction bone plate. Basically, guys, this is a bulky plate which contains minimum of 3 screws. Say suppose 3 screws on one end, 3 screws on another end, so that there is very the plate is taking up all the load. So we are putting a bulkier load, or sometimes this fixation is also known as the bridging fixation. So it is also known as the bridging fixation. Now, coming to load sharing is wherein like it is kind of internal fixation that is of insufficient stability to take up all the load. So the functional loads are taken up by the bone as well as by the plate also. So this is seen in case of like simple fractures. So in case of simple linear fracture, we see that there is load sharing kind of fixation. So we put the mini plates. For this, mini plates can be a good example for the load sharing. So mini plates, and then because plates are not bulky, so the bone is also taking up the load, or the lag screws, they are the example of load sharing. So guys, let's talk about the third principle we have is the locking versus non-locking plates. As the name suggests that these locking plates will have locks in their plates. Non-locking plates will not have locks in the plates. What do we mean by the term? See, locking plates are basically these plates, guys, in which the hole contains the threads like this. So this is the locking plate wherein the whole of the plate is having the threads and the screw is also having the threads. So guys, this is the screw. So say this is the screw. So the screw head is also having the threads or the serrations, you can say. So locking one are with the threads or the serrations in the screw head and also in the whole plate, so that the screw gets in the plates and engage very tightly. So this is for the locking. So there are no chances of infection since it is locked very nicely. So this is the added advantage of the locking plate over the non-locking plate. Now non-locking plate does not have any locks. Therefore we need to counter this plate to the bone surface. Now say suppose bone is bone is not straight line, right? If you see from a bone surface, it is going to be like grooves and fossas like this. So what happens while you are placing a plate like this, say, and then in the hole you are placing the screws. Now for non-locking plate system, you need to adapt this plate according to the bone. So need to adapt the plate to the bone so that the screw doesn't open up. So therefore this kind of plate has got more chances of having infections, and that's the difference between the locking and the non-locking plate. Now we have the fourth principle, which is the compression versus non-compression plates. Non-compression plates. Now guys, the difference between both of them is like these compression plates are kind of lovers. So they are going to take both of these fracture segments together. I mean, they are going to pull both the fracture segments until they meet. But the disadvantage of this is that sometimes there can be overriding like this. So if they are pulling it so badly, there can be overriding of the fracture segments, right? Overlapping or overriding. And what happens if this is overriding at the angle? So if it is happening at the angle, the mandible become more wider. So that is the reason we usually go for the non-compression plates, right? Because they are pulling together. Now talking about the non-compression plates which we use most widely. So guys, compression plates, we have got two types. One is the dynamic compression plate. And other one is the eccentric dynamic compression plate. So how this plate pulls the both fragment together is, first of all, like say these are the broken fragments of the bone. So say these are the broken fragments. So we place the plate and the screws inside this fragment. So first it goes down, then what happens, both of these screws, they start sliding towards the center of the hole. So hole in this case is not circular, it is in fact kind of oval. So what happens guys, like this. So not, one second guys, now let me redo it. So the holes are kind of like this. You are placing these screws in the oval holes, and these screws are placed distal to the fracture segments so that there is space for the movement of these holes. As you can see, there is some space for the movement of these holes. So these two fracture segments are pulled towards each other with the help of these screws in case of compression plates. So how this movement occurs is, this is a plate say, and here we are going to place the screws like this. So the movement which is happening is, first there is down and then there is forward movement like this. So this based on the principle of the spherical gliding principle. Now imagine that this is a sphere. This is a sphere, right? Now if something we pass through this sphere, say there is a ball, and if this ball is passing, first this ball will go down, reaching up till here, and then this ball will slide or incline little bit, right? So this part, if we take only this much cross section, this is the exact principle which is used in the compression plates. So this is the particular kind of movement which takes place in the compression plates, and this is how both the fracture fragments are pulled together towards each other. Now as I told you that there are two kind of plates. One is the dynamic compression plate, one is the eccentric dynamic compression plate. So guys, if you look at the dynamic compression plate, it contains two compression holes and two retentive holes. So these are the two compression holes which are ovoid, and then there are two retentive holes which are round. So the retentive holes, and then we have the compression holes which are oval in shape, compression holes, and we put the screws here distally so that there is a window to slide over of these screws. So first of all we put the compression screw, then we put the screw in the retentive hole. But what happens if these dynamic compression plates are placed in the inferior border? Say suppose this is the mandible anterior region, and if you have put a compression plate over here, and this was the fracture. So if you have put these two fragments will start pulling each other. Once they start pulling each other, guys, what it becomes is like this. Since there is pulling at the inferior border, say this was a plate, since the fracture fragments are pulled only across this plate, so here at the inferior border they will unite, but there is going to be no unity at the superior border. So this is what do we call, there is release of tension. So there is a compression and tension, and because of that the upper or the superior border of the bone or of the mandible opens up. So we need to put either one plate over here, or you can put one screw over here, so that the fragments are not getting apart from the superior border. So what we do is, we go for the eccentric dynamic plate, eccentric dynamic compression plate. Now the added benefit of this eccentric dynamic plate is that it has got two extra screws. So 1, 2 and 3, then we have this plate 1, 2 and 3. So one is, if you remember, that oval holes which are the compression holes, then the round one, these are the retentive holes, and guys one more hole extra, I mean two extra screws, there is placement of two extra screws, and these holes are oblique. So this is the added benefit of the eccentric dynamic compression plates, because these extra oblique screws, they counteract the tension released during the dynamic compression plate, right? So these oval holes are the compression holes, then these are the retentive holes. Basically it is used to release the tension, right? This was about the principles of plate fixation. Now talking about the screw. So say suppose this is the screw head, then we have got these threads. So basically this screw is like a screw which we use in implants, or kind of the screw which is used. If you have seen the screws which we use in the wall, looks like that. So these are the lag screws. You can say lag screw. So there is a head. Head can be locking or non-locking. If the head has got threads, we call it the locking. If it has got no threads, then we call it non-locking. Then the thing between the two threads is what we call the pitch. Then we have got the tip. This is the tip of the lag screw or the screw. There are two diameters. One is the inner diameter, which we call the core diameter. Core diameter. The another diameter is this one, which we call the outer diameter. So if you want to use a screw for maxilla, so maxilla is a cancellous bone, so we need to use a screw for the less dense bone. So for pitch is increased for the cancellous screws, cancellous bone, or we can say the maxillary, and a decreased pitch screw is what do we use for the cortical bone or the mandibular bone. Right. So tip can be again self-cutting or self-tapping tip. So guys, how do we use these lag screws? So say suppose this is a fracture segment of the bone. Now what we need to do, we need to prepare holes first for these fracture segments. We approximate these segments together, and then we prepare a glide hole which is drilled perpendicular to the fracture segment. So say this is a hole, this is a hole which is drilled perpendicular to this fracture segments, right? So this is the first hole which we made perpendicular to the fracture segments. This is known as the gliding hole or near hole. Right, this is called glide hole. Now we make another hole which is equal to the core diameter. See, this gliding hole or the first hole, guys, is the dimension is same as the outer diameter of the screw. Then the second hole which we prepare, this one, one second guys, so this one which is equal to the core diameter, which is the inner diameter of the screw, right? So that is also again perpendicular to the fracture, and this diameter is what do we call the threaded or the far hole or the pilot hole. Now once this pilot hole is made, which is equal to the inner diameter as the screw size, so we glide the screw through this glide hole, through the cortex, and then engage into this pilot hole. So this is the glide hole through one cortex, then we have the pilot hole through the other cortex. We engage into the glide hole, into the pilot hole, and then we compress both of these parts. So that's how we place a screw, guys. So this is how, say suppose these were the two fragments, then we made first glide hole, then we made the pilot hole, and then we put the screw over here. So then we put the screw over here like this. So this is using the lag screw. But the drawback is that it does not resist the bending or the shearing forces at your will. So you cannot trust a single lag screw about it, either it is going to secure the fragments or not. So we usually go for a plate. If we are using the screw, then we, along with that, we go for a plate also. So guys, now you have understood whole of the concept when we go for the rigid fixation. Rigid fixation consists of the primary bone union, which is the direct bone union. Then there is non-rigid fixation. Non-rigid fixation is when all the fragments are very tightly secured. There is not even micro movement which is happening. Then we have the non-rigid fixation, wherein there is some slight movement which is happening. Say you have placed a wire across the mandibular fracture, so that will be a kind of a non-rigid fixation. Basically it is the functionally stable fixation. So then we have also studied the load bearing and load shearing. So in case if there is a comminuted fracture, or there is atrophy of the mandible, so all these cases we do not want to put the load on the bone. We want the plates to take up all the load. So in that case we go for the load bearing fixation. And the another one is the load shearing fixation, wherein the bone shares the masticatory or the functional load along with the plate. So in the case where there is a normal single linear fracture, we usually go for the load shearing fixation. Then we have also covered the compression and non-compression plates, the dynamic plates. We have also studied 1 point and 2 point fixation. 1 point fixation in case of body or angle, wherein we can only put one plate. That will also ready to go. There is no harm. We do not have to go for many or 2 point fixation. But in case if there is anterior mandible fracture, that is symphysis or parasymphysis fracture, say, or sometimes in the body fracture also, we need to put two plates, one in the superior border of the mandible, another one is the inferior border of the mandible along the Champy's line. So that is the 2 point fixation. We also have covered the compression, non-compression plates and the reconstruction plates, which are the bulky plates. So you will find with the 6 hole, like a plate like this with the 6 holes, 1 2 3 one side and 1 2 3 another side, like so, like this, six holes. This is if you are using only one 6 hole plate, that also gives you the rigid fixation because that is very bulky. So all that we have covered, that includes all the principles. Now we will be starting with the fractures from the next lecture series, next video lecture. I hope that you have enjoyed this lecture and you have understood the concepts, the principles of the fixation. And when we go for fixation, wherein we are going for open reduction. When we are doing close reduction, we go for intermaxillary fixation. So if you have enjoyed the video, give it a thumbs up. Also comment in the comment section, because this motivates me to put more videos for you every day and to make free notes. So if you want to support us, you can support us on Paytm as well as on PayPal to make more free videos like this. And guys, keep reading, keep learning, stay motivated. I'll see you soon in the next lecture.